My name is Emmanuel Mensah, and today we'll be talking about liver function tests. First of all, we want to know a way that you'll be able to distinguish hepatocellular injury from a cholestatic injury. In that, if a patient comes to your consulting room and then just looking at the liver panel or the test that has been given to you, you'll be able to accurately predict that this patient that I'm seeing over here has a hepatocellular injury or a cholestatic injury, or the patient might have a mixed condition. Okay, so that's what we're going to talk about. But before we start, we want to know a brief information concerning the liver function test. Okay, so the liver function test is actually divided into three. We have tests for liver biosynthetic capacity, we have tests for cholestasis, and then tests for liver cell injury. Okay, when you talk about the test for the liver biosynthetic capacity, we have albumin, we have prothrombin time, and then we also have total proteins. Okay, they are there, but then we just want to discuss these albumin and then prothrombin time. Now, albumin is probably the most important protein that is produced by the liver. It is responsible for the maintenance of plasma oncotic pressure. Okay, responsible for the maintenance of the plasma oncotic pressure. It has a normal range of about 3.5 to 5 grams per deciliter. Okay, this is the normal range that it falls into. Albumin usually has a half-life of about 20 days. Okay, so it's said to have a very long half-life, and because of that, it is usually implicated when it comes to chronic conditions. So if someone has a chronic liver condition, you actually expect the albumin levels to decrease. Okay, yeah. Now, in situations whereby the liver is damaged, okay, or there is liver cirrhosis, the production of the albumin is going to be decreased, and that is going to affect the plasma oncotic pressure. So what happens is that fluid might seep from the vascular tissues into the interstitial spaces, and that will cause edema. So if the fluid accumulates inside of the peritoneal cavity, then you are going to have ascites. Okay, you have ascites. And as a clinician, if a patient presents to you in your consultation having ascites, you would want to know the cause. You want to evaluate the cause. And so evaluating the cause of ascites, we use SAAG, okay, which stands for serum ascites albumin gradient. So you do that, and then if you get a value that is greater than 1.1, then it tells you the cause of the ascites is portal hypertension. Okay, portal hypertension. If it's not that, then it means that the cause of the ascites is from something else. Okay, yeah, so that is basically what we'll be able to talk about under albumin. Okay, so now we'll move on to the prothrombin time. Okay, now prothrombin has a half-life of about, so the half-life of prothrombin is about 6 hours. Okay, it has a very short half-life, and because of that, it's usually implicated when it comes to acute conditions. Some textbooks or literature might say it indicates the present function of the liver. Okay, so that is the acute condition. Now, prothrombin time accesses the extrinsic pathway when it comes to the coagulating system. So your liver is able to produce the clotting factors in their right proportions, and that will influence the prothrombin time. Okay, so that's what we are talking about here. Now, in conditions, in liver condition, whether the liver is diseased, whether it is cirrhosed, it means that the ability of the liver to produce the clotting factors is going to be impaired. Okay, and in that regard, your ability to clot is also going to be impaired, and then you have an increased prothrombin time. Okay. Usually, when you're talking about prothrombin time, we'd also want to discuss vitamin K. Okay, its relation vitamin K. So we want to assess the vitamin K function too. So the patient presents to you in your consulting room, you take your history, do your physical examination, and then you request for liver function test. Then they bring your lab results, and then you see the value. You see that prothrombin time has increased. Okay, so you'll be thinking, is this prothrombin time or is this increase in the prothrombin time actually coming from a liver condition, or is coming from a vitamin K deficiency? Okay, so you'd want to know the distinction between that. And what you do is that you give intravenous or parenteral vitamin K. Okay, so if the patient is actually suffering from a liver condition, when you give the intravenous vitamin K, the prothrombin time will still remain increased. It will not decrease. Okay. But then if it's a vitamin K deficiency, upon administration of the intravenous vitamin K, it will be able to stimulate the liver cells to produce the clotting factors, and therefore will reduce the prothrombin time. Okay, so that is how we do certain things. You should also understand that the liver is also responsible for producing thrombopoietin. Okay, thrombopoietin. Now, thrombopoietin, when produced, will stimulate the bone marrow, and the bone marrow will produce platelets, okay, which will help you in your blood clotting system. when the liver is diseased or when the liver is cirrhosis, production of thrombopoietin is going to be decreased, and then the stimulation to the bone marrow will also be decreased, and the production of platelet will also be decreased, and that will lead to thrombocytopenia. Thrombocytopenia. Okay, that will lead to thrombocytopenia. Now, if you have thrombocytopenia together with increased prothrombin time, and then having a risk of bleeding, the patient has a risk of bleeding. These three will combine together to form what we call a coagulopathy. Okay. A coagulopathy here, you can say, is somehow similar to DIC, disseminated intravascular coagulation. So you have that. Okay, and so you want to distinguish if the patient is actually suffering from a liver condition, or the condition the patient presenting is actually DIC. So what you do is you give a clotting factor that's not produced by the liver, and that is factor 8. Okay, that is factor 8. Factor 8 is not produced by the liver, and so that's what they use usually. So you test for the levels of factor 8, and then if the person is actually suffering from DIC, you expect factor 8 levels to go down. If it's a liver condition, factor 8 levels will go up. Okay, so that's what we can say. Now we come to test for cholestasis. And under the test for cholestasis, we talk about total bilirubin. We're not going to talk about the pathway though, but then we should understand that total bilirubin is equal to the direct bilirubin or the conjugated bilirubin plus the indirect form of the bilirubin or the unconjugated bilirubin. Okay, now you should also understand that you can actually get bilirubin from hemolysis of red blood cells. And also you can get it from myoglobin and the cytochrome P450 enzyme. Okay, yeah. Now excessive accumulation of bilirubin will cause jaundice. Usually it causes jaundice. Okay, so you also want to know if this condition that the patient is presenting with is actually jaundice or carotenemia. Okay, because carotenemia also presents with yellowish discoloration of the extremities. And so how would you know that this condition the patient is presenting with actually jaundice or it is carotenemia? Now what you do is that jaundice is caused from excessive accumulation of bilirubin. Okay, and bilirubin has a very high affinity for elastic tissues. Okay, so high affinity for elastic tissues. And the sclera is part. Okay, the sclera is made up of lots of elastin. And so the bilirubin will be able to accumulate over there, and that will cause the yellowish discoloration of the sclera that you see. In other words, jaundice will always present with yellowish discoloration of the sclera, and carotenemia cannot present with yellowish discoloration of the sclera. Okay, yeah, so that is basically what we will talk about there. Then it's also implicated when it comes to neonates. So in neonates, if there is excessive accumulation of bilirubin, it can cross membranes and get into the basal ganglia, thereby causing connectors. And so we always want to prevent connectors. And so when the neonates are born, what we do is that we do phototherapy. Okay, so we subject them under blue light, and that blue light will be able to lyse the bilirubin that is formed and convert them into lumirubin. Okay, lumirubin. This is the product that is formed from phototherapy, and this one is excreted by the kidney. Okay, so the kidneys will be able to excrete the lumirubin. Yeah. And also, if someone has a prolonged obstructive jaundice, okay, now you should be thinking about delta bilirubin. Okay, delta bilirubin. If someone has a prolonged obstructive jaundice, in the sense that, okay, so we should also be thinking about delta bilirubin in the sense that the conjugated form of the bilirubin will covalently link to albumin, which is usually not filtered by the kidneys. Okay, and this explains why conjugated hyperbilirubinemia may occasionally persist even after bilirubinuria has occurred. Okay, so we move to alkaline phosphatase. Now, alkaline phosphatase is not liver specific. Okay, not liver specific. Okay, it is not liver specific, and so if the increase in bone cells could actually cause increase in ALP. And even pregnancy, the placenta could also cause an increase in ALP. We also have dermaglutaryltransferase. Now this one is liver specific and mostly implicated when it comes to alcoholic conditions of the liver. Okay. Test for liver cell injury, alanine aminotransferases. That is the ALT. This is liver specific. Okay. Liver specific. And then only in cytosol. Only in the cytosol. Then the AST is not liver specific because you can actually find it in skeletal muscles. You can find it in red blood cells. You can also find it in the cardiac muscle. So if someone presents with a rhabdomyolysis, you should expect AST levels to go up. MI, myocardial infarction, AST levels will go up. Or excessive hemolysis, AST levels will go up. So not liver specific. Okay. Not liver specific. Alright, so I think this should be enough for the introduction. So now we'll move on to the most important part that we wanted to talk about. Okay. Alright, so now we want to talk about the R value. Okay. Now, according to the American College of Gastroenterology, they proposed guidelines, okay, for drug-induced liver injury. Okay. And what they said was that's where they proposed the R value. Now, the R value, it's very necessary. It actually tells you the relationship between ALT and then ALP. So we initially discussed ALT, if you remember. So we initially discussed ALT, if you remember. We also talked about ALP, okay, where we said ALT, alanine transaminase, is specific to the liver. ALT is specific to the liver. But we said ALP is not specific. Okay, we said GDT was rather specific, but I don't know why they didn't use GDT, instead they used ALP, so we take it like that. Okay, yeah, so it tells you the relationship between ALT and actually predicts whether the patient's condition is actually hepatocellular, that is coming from the liver, or it is a mixed condition, or it's a cholestatic condition that is coming from the gallbladder or the bowel. Okay, so they said our value is always equal to the measured ALT value, that is from the panel that you got, divided by the upper limit of the normal ALT. Then you divide everything here by measured ALP levels divided by the upper limit of normal of the ALP. Okay, so that was the formula that they proposed. And so if you check it right, you realize that ALT is on top, so telling you hepatocellular injury divided by ALP. Okay, so this is the numerator and this is the denominator. Okay, so that is what we were talking about here. And so this is the formula that was proposed. And so they said if you get an R value, okay, after doing the calculation, then you get an R value greater than 5, then it's telling the patient has a hepatocellular condition. Hepatocellular. If you get an R value greater than 2 but less than 5, you have a mixed condition. Okay, and then if you have an R value less than 2, then the patient will have a cholestatic condition. Cholestatic. Okay, so these were the values that was proposed. All right. So now we are going to try the first example that we have over here. The patient has a measured ALT. Now you should understand that the patient will not present this way. When you do the liver panel or the liver biochemistry or the liver function test, you have all the parameters in there. But then because of the calculation of the R factor, we just decided to pick the ones that relate to the R factor. Okay. So solution to this problem, of course, you've read the question. You can actually pause the video in here and then you try to solve it, get your R value, and then give the inferences, then you compare your answer. So the patient has a measured ALT value of 200. So you have 200 on the normal ALT level, which is 40. Okay. Then I divide everything here by the ALP level that was given, that was 90, divided by 120. Okay. And that should give us an R value of approximately 6.7. So if you have an R value of approximately 6.7, this is greater than 5. And that tells you the patient has a hepatocellular injury. Okay, or damage. Okay. Alright, so move on to the next one too as well. Example 2. You can pause the video and then you try solving it as well. And then when you are done, we will discuss it together. Okay. So solution to this example. Alright. So our value will be equal to ALT, that is 480. 480 divided by the upper limit of normal of the ALT, that is 40. Then I divide everything here by upper limit of ALP level, that's 380, divided by upper limit of normal of the ALP, that is 120. And that gives us approximately 3.8. And this falls within the range of 2 less than R less than 5. It falls within this range. Okay, and that tells us this patient has a mixed condition. Okay, all right. Then the last one that I'm going to do for this problem is to so the patient has a measured ALT of 949. Okay, so solution. So R value will be equal to 49 divided by 55, or divided by 285 over 110. That will give us an R value of 0.34. This R value is less than 2, and so it tells us the patient has a cholestatic injury. Alright, so that brings us to the end of our discussion. I hope you understood the concepts very well. Thank you so much for your time, and God richly bless you.